Hello everyone. Welcome to this ISAC webinar, which will be presented by Dr. Jaime Lora-Tamayo from Spain. This webinar is co-hosted by the International Society of Antimicrobial Chemotherapy and the China Agricultural University. I'm Jaime from Monash University in Melbourne, Australia. So this webinar will be co-chaired by Dr. Su Nang and myself. So before we start, I just spend a couple of minutes on ISAC and the China Agricultural University. So ISAC is an international society on antimicrobial chemotherapy, and it aims to advance the education science of antimicrobial therapy. It has very strong partnerships with 93 member societies globally. And if you want to know more information, please do go to this website. And we also have an anti-infective pharmacology working group. So our working group focuses on promoting international exchange of ideas and new research of all aspects of anti-infective pharmacology. So this is the leadership group in our working group. And Dr. Lora-Tamayo is the chair. So if you want to join our working group, please feel free to spend maybe 2 or 3 minutes to finish this registration at this website. It's totally free. And importantly, we have a young investigator committee, which is co-chaired by Dr. Su Nang and Amy Huang from USA. And this young investigator committee mainly focus on facilitating interactions among young fellows in our group. So I think it's very important to build up a network for the young fellows so they can explore more opportunities for their career down the track. And for China Agricultural University, it was established in 1905, one of the oldest and the best agriculture university in China. It had more than 70,000 students, including more than 7,000 high degree research students. In the latest 2021 international ranking, it ranked the best or second university in agricultural sciences. It depends on which ranking. So clearly it's on the top internationally. The China Agricultural University also has international partnerships, very strong international partnerships with a large number of universities globally. And particularly, there's a College of Veterinary Medicine. It has a strong research and teaching faculties. And also important, they have more than 10 national and ministry key laboratories, very well equipped. They publish certainly a large number of papers every year. So for this webinar, we disabled chat and video for security purpose. So if you have questions, please go to this reaction, raise your hand, and then one of us will unmute you, and then you can introduce yourself briefly and ask question. Alternatively, if you're too shy, you can send an email to us, and Sue is monitoring email, and we will answer your question. So it's my great pleasure to introduce our speaker today, Dr. Jaime Lora-Tamayo from Spain. Jaime obtained his MD in 22 and a PhD in 2014 from the University of Barcelona in Spain. He's currently a physician at Department of Internal Medicine, Hospital University in Madrid, Spain. He has published 72 papers and book chapters, and also have more than 90 conference presentations. He holds multiple leadership roles nationally and internationally. Particularly, he's the chair of our anti-infective pharmacology group at ISAC. And at the moment, he's associate editor of the Journal of Bone and Joint Infection. So today, he will talking about biofilm-related joint infections. Now I hand over to Jaime. He is yours. The stage is yours now, Jaime. So feel free to share the slide. Thank you.
Okay. Right. I'm sharing now.
Oh, good. If you could use a full screen, that would be great.
Just a minute. Okay. So can you see the presentation? Is the screen?
Perfect.
Yeah.
Perfect.
Okay.
Thank you.
All right. Okay, Jan, thank you very much for your kind words, and thank you, the ISAC and the Channel Cultural University for their kind invitation to share to share these moments and this talk with you all. As Jan was saying, I'm a medical physician at the Hospital Universitario de Octubre in Madrid. I am a consultant in the surgical wards and namely in the orthopedic wards. And so I just see patients every day in the orthopedic wards. Many times they have infections associated with their orthopedic material. So this is pretty much my routine every day. And this is what I want to share with you in the following slides. This is the outline of my talk. I will go very briefly through what is a biofilm and where we get biofilms in nature, and overall problem of the biofilms in humans. What are the treatment difficulties in the biofilm setting? I would like to spend some minutes just discussing what is the best approach to the study of antimicrobial activity in the biofilm context. And finally, with all these introductory concepts, I would like to go to the main things of the problem we have with prosthetic joint infections. So let's move on then. These are what bacteria look like in the laboratory. As you probably know, this is a gram staining where we can see gram-positive cocci, which are they have a smooth surface. And with this knowledge that we have had for the last maybe 200, 300 years, we had very important information on bacterial properties such as morphology, virulence properties, antimicrobial susceptibility, and so on. No? So we have a lot of information from the common lab, but these bacteria are very different from what we find in the environment. Bacteria do not look like the bacteria we get in the lab. They look more like the bacteria I'm showing you in this microscopy photograph. And this is more recent knowledge. This comes from the 60s and 70s of the last century. John Costerstone was one of the most important researchers for discovering us the importance of biofilm. And you can see that if the bacteria on the right-hand side look very smooth, the bacteria in the electronic microscope photograph is very different. The shape is different, the morphology is different, and it is very important, this corona that they have, the bacteria have around them, these kind of spikes that they have, which is the glycocalyx. And the glycocalyx, which we don't have them in the common lab because the enrichment growth makes the bacteria that are growing without glycocalyx with more advantage. This glycocalyx is very important in nature, and this is what allows bacteria to attach to surfaces. So here on the left-hand side, you have a diagram of what the glycocalyx is. That, as you know, is a mixture of chains of carbohydrates that connect the cell wall, the bacterial wall, with inner surfaces around. And this allows bacteria to make bonds with the surfaces with the environment, which are very strong. On the right-hand side, you have a very old microscopic photograph from 1978. And in the low part, I am trying to depict what we are seeing. And what we're seeing is a bacteria that you can see here that is fighting against a current, a flow that tries to expel this bacteria from the photograph. But the bacteria can resist this because it is attached to this surface thanks to its glycocalyx. So yes, bacteria in the environment have a glycocalyx that allows them to attach very strongly to surfaces. And once they have attached, they are able to excrete a mixture of proteins, genetic material, DNA, and especially carbohydrates that make a kind of a matrix in which bacteria become embedded. And this is what is the biofilm. In this matrix, in this slime, the bacteria are protected and they can grow and expand and eventually specialize. And some of these bacteria can be released again and then float again, become planktonic again, and colonize new surfaces. So this is a process that can happen very quickly in nature. Here you have some electronic microscopic photographs of Mycobacterium fortuitum biofilm, and you can see that in a couple of days, you can see grossly this slime that connects all these bacteria. And in less than a week, you have a very sophisticated form of growth, which is the biofilm. You can see here highlighted the formation of inner channels within the structure of the biofilm that allow the penetration of fluid and nutrients and oxygen into the biofilm. So biofilms are a protected mode of growth and survival in hostile environments that the majority of bacteria have. These are far from being inert structures. They are quite complex. They are metabolically quite active. They have inner channels. They allow the differentiation of bacteria according to the specific location within the biofilm, because the bacteria in the superficial layers of the biofilm will have different nutrients and concentrations of nutrients and oxygen as compared with bacteria in the deeper layers of the biofilm. So they will be different. They will be able to excrete different molecules. And these different molecules is what we call the quorum sensing, because they allow them to communicate between each other. There are some researchers that have compared biofilms with a tissue-like structure, meaning that the bacteria differentiate and each one of them has its own properties and functions. So on clinical grounds, we physicians are quite simplistic. We differentiate bacteria from exponentially growing planktonic bacteria and those coming from a biofilm, those that are dormant. And of course, that's really a continuum. And we have many different phases where the bacteria can be less or more active from a metabolical point of view or from a growing point of view. And you have here a classification of bacteria, which is quite complex. We use this more simplistic black and white classification of biofilm-embedded bacteria and planktonic bacteria. And this is what I will do, but bear in mind that this is more complex than I pretend to. Biofilms are not only in the hospitals, they are in many parts. They are a big problem for industry. This is what is called the biofouling. We have microbiofouling when we are referring just to bacteria, but we also have macrobiofouling when we are referring to the fouling made by small animals, especially seafood. And you see different examples of what can happen in pipelines, air exchange systems, cooling water industry, and so on. In the case of the Navy industry, this is a very big problem. Ships have a lot of places where biofouling can be a big problem, such as the propeller, such as the hull of the ship, such as the anchor, and so on. And this is important because this costs money. This reduces the efficiency of the systems, and this costs money at the end of the day. So there's a lot of interest in the industry for treating and dealing with biofilms, to which maybe sometimes we can make profit in the clinical, in the hospital. But we are talking about infections, and I will be talking about prosthetic joint infections, but we have many other devices where biofilm can develop. We have, for example, dental implants. We have intravenous lines that can become infected. We have many types of intravascular devices, such as pacemakers, prosthetic valves, vascular grafts that can become infected where biofilm develops. We have breast implants that can become infected. We have devices in the central nervous system, such as the cerebrospinal fluid shunt devices that can get infected too and develop biofilm-associated infections. We have prosthetic joints, of which we will talk in a while. We have abdominal meshes for repairing abdominal defects. These all are foreign bodies that where bacteria can attach and develop biofilms. But we have biofilms even when we don't have prosthetic material or foreign bodies. We have several infections where bacteria do not have the planktonic way of growing, but the biofilm way of growing, such as caries, which is the most frequent infection worldwide anytime. We have chronic otitis. We have bronchiectasis, which is quite a problem in patients with cystic fibrosis and others. Of course, we have native valve endocarditis, chronic osteomyelitis, diabetic foot infection, chronic prostatitis, and so on. And here we will have the biofilm problem too, and so the difficulties of treatment. And why are biofilms so difficult to treat? There are many reasons. One of the most important reasons is a pharmacokinetical problem. which means that the antimicrobial may never reach the bacteria that is said to be treating. And this may be because of a slow penetration in the biofilm, slower than its clearance. It may be because of entrapment of the antibiotic, because of adsorption of the antibiotic in the biofilm matrix. It may be because of the inactivation in the extracellular matrix, for example, the presence of extracellular beta-lactamases or beta-lactams. And it can also be because of denaturalization of the molecule according to the specific physical properties of the biofilm or the biofilm layer. This is, for example, the case of aminoglycosides and the acidic environment that we find in the biofilm. There's also a problem in the biofilm with the immune system. The immune system is simply unable to clear the infection. There's an inhibition of immune cells within the surroundings of the biofilm. And in fact, the bacteria can use the macrophages and other immune cells to invade them and act as a Trojan horse, and so to evade the immune system and persist intracellularly. So there is an ineffective inflammatory response that may be, in fact, responsible for some of the patient's signs and symptoms, but is unable to clear the infection. There are some genetically programmed ways of persisting in the biofilm too. Examples of these are the small colony variants that you can see in the left-hand side photograph, or the persisters themselves. These are genetically programmed ways of persistence where some bacteria just renounce to growing, renounce to doing specific functions within the biofilm, but they just are aimed to persist, and they are quite resistant to any kind of antimicrobial or antibiotic or environmental situation that can lead to bacterial killing. And what is very important for us is that bacteria, regardless if they are small colony variants or not, bacteria in the biofilm, they experience some phenotypical changes that lead ultimately to antimicrobial tolerance. And this is quite an important concept for biofilm, and this is what will, at the end of the day, be why we can't treat biofilm so easily. And on the left-hand side, you have what we know as MIC and MBC, minimal inhibitory concentration of the antibiotic, minimal bactericidal concentration. We'll go with the definitions in the next slide, but we know that if the antibiotic is over the MIC and the MBC, then we will have antibiotic killing, and we will say that there's antimicrobial susceptibility. What happens in biofilms is that the MBC increases a lot over the antibiotic concentration that we can give to the patient on clinical grounds, and so there will not be an effective bacterial killing, and this is what we call antimicrobial tolerance. This concentration that rises so much is what we will call in a few slides minimal eradicatory bacterial biofilm concentration, as we will see. So you all know, I guess you are familiarized with the concept of MIC and MBC. MIC, minimal inhibitory concentration, is the minimal concentration of a given antibiotic that inhibits the growth of the bacteria. So it will be the first where no visible growth is seen in the growth media. Still, if we cultured this media, we would still recover some bacteria. So this just inhibits growth and does not kill bacteria. What kills bacteria or kills the most part of bacteria, set in 99.9% of the population of a given bacterial population, is the minimal bactericidal concentration. These concepts are very, very useful and are very, very important on clinical grounds for most of the infections that we treat, such as pneumonia, urinary tract infections, skin and soft tissue infections, bacteremia, meningitis, you name it. But the important thing here is that MIC and MBC are not reliable for biofilm infected infections. They don't provide useful information in this setting. So do we have any other index other than MIC and MBC for just measuring how much resistant or how much tolerant are biofilms to antimicrobials? Well, this is the Calgary biofilm device, which was set in 1999 by Seri and other colleagues from the Calgary University. And this is quite similar to an MIC, but the difference is that you can see that in this micro 96 well microtiter plate, there's a lid, and this lid has some pegs, and these pegs fit perfectly well in each one of these wells. And these pegs are used to develop biofilm. So we confront the leads to the wells where the bacteria are growing, and then the bacteria attach to the pegs, and then some biofilm is developed in the pegs, and then we confront the biofilm in the pegs to different concentrations of antibiotic. And then the minimal concentration where biofilm is not developed anymore is what we call the minimal eradicatory biofilm concentration. And this is what we think is the measure of the MBC of biofilms. Here you have an example in this table of that compares MICs for Staphylococcus aureus of different antimicrobials with MPICs. And you can see a dramatic rise in the concentration that you would need to eradicate biofilms as compared with MIC. See, for example, cefazolin rises from 0.5 milligrams per liter to more than 1,000 milligrams per liter, meaning that indeed biofilms are tolerant. I will criticize the Seri biofilm device in a few slides, talking about the clinical meanings of this data, because we know that MIC are important for planktonic infections, but it is still to be proven that these numbers are clinically relevant for biofilm-associated infections. Here's another example of MICs and MPICs, MBEC, so bactericidal eradicatory concentration. And you can see that this is a collection of Staphylococcus aureus recovered from prosthetic infections. And you can see that here you have the susceptibility of these antimicrobials according to planktonic criteria. For example, daptomycin here at the bottom of the table, you see that all the strains of Staphylococcus aureus are susceptible, but then the MBEC concentration are very, very higher, far beyond what we can reach on clinical setting. So from a very, very practical point of view, for us physicians who are not microbiologists, we could set like a ranking, like a traffic lights, red, very bad, and green, very good. We can pass for antimicrobials, meaning that all antimicrobials develop tolerance in the biofilms, but not in the same measure. So it is not the same, the tolerance developed to, for example, rifampin and fluoroquinolones as compared with beta-lactams and glucopeptides. We know that rifampin and fluoroquinolones are quite good for biofilms, and we will discuss this later on, whereas beta-lactams and glucopeptides do not perform very good in biofilms. And this is quite different from planktonic infections, because if you think about it, the treatment of choice for pneumonias, urinary tract infections, meningitis, and so on are penicillins, are beta-lactams, but this is not the case for biofilms, so this is important. So what are the variables that predict a higher tolerance to antimicrobials within biofilms? There are two which are quite related, which is the biofilm density in a given biofilm, and also the age of the biofilm, what is also called the maturity of the biofilm. And these graphs show us that the higher the cell density and the older the biofilm, the less susceptible to antimicrobials they will be. The reduction of cells will be less for a given dose of antibiotics. And of course, these two variables are quite related, because the older the biofilm is, the more mature, the higher the likelihood that bacteria have grown inside the biofilm, so the higher the cell density. But some researchers have shown that if they can manage to get the cell density constant over time, then the maturity of the biofilm is the most important variable predicting the tolerance of the antimicrobial. And this is important because this means that biofilms that are very, very young, we have a chance to treat them, whereas biofilms that are very, very old, very, very mature, then antimicrobials will do nothing against them. And we will recover this concept when we will talk about prosthetic joint infections. So, okay, we know about biofilms since 30, 40 years ago, but biofilms have existed since many, many centuries, since the beginning of the world. So how did people before treat biofilms? Well, with surgery, you can see them. If you have a biofilm problem, you just remove the foreign body and then you cure the biofilm. And of course, we still do this, not so dramatically as depicted in this picture, but we operate patients. We indicate operations for treating patients with biofilm-associated infections. But you have to, we need to be empathic, sympathetic with these patients, because you can imagine that for this child that benefits from a CSF shunt device for his hydrocephalia, removing the device is a problem. He will need another device, and this means 2 operations. And it's the same for prosthetic joints. If we remove the prosthesis of this patient, then he will have to go to bed or to a wheelchair. Okay, we are going to cure them by removing the foreign body, but we need more solutions apart from that, no? So how can we improve our knowledge on biofilm? Well, I refer the audience to this very, very nice review by Dr. Coeni and Dr. Nealis about in vitro and in vivo model systems to study biofilm formation and biofilm susceptibility. Grossly, we would have, of course, in vitro and in vivo systems, and inside in vitro systems, we have microtiter plate-based systems such as the Seri Calgary device that I was explaining before, and also the flow displacement systems. These are reactors that are able to grow biofilm and treat them during several days. There are many different examples. I myself have worked with this one, which is quite known, which is the CDC biofilm reactor. The difference between static and dynamic systems is this one. There's an important difference. In static systems, we don't exchange the media, so we have an accumulation of the product of waste, the metabolic products of waste, and we have a reduction of the substrate of the feeding to the bacteria, whereas we can keep these variables constant in a flow displacement system, in a dynamic system, and so we can perform better experiments and longer experiments throughout time. I said before that I wanted to make some criticisms of the Calgary device. I was explaining before that the Calgary device provides us with some idea of how tolerant biofilms can be, but it is still to be proven that this is clinically relevant. This is some data from my lab. On the left-hand side, you have the activity of levofloxacin and rifampin against a collection of Staphylococcus aureus recovered from prosthetic joints. And you can see that the response to either levofloxacin or rifampin is quite heterogeneous. You can go from 1.5 reduction logarithms to 3.5 in the case of levofloxacins, and from 1 to 3.5 in the case of rifampin. And I wonder, is the MBEC that the Calgary device able to predict how much active will be levofloxacin or rifampin? The answer is no. If I confront this reduction of biofilm-embed bacteria that I get with levofloxacin or with rifampin with the MBEC that I had previously calculated with the Calgary device, I have no correlation. So I guess that the Calgary device, which is an static tool, provides us with an idea of how tolerant antimicrobials, biofilms will be to antimicrobials, but it is not as reliable as the MIC for planktonic infection. That is the point of this slide. Regarding in vivo models for approaching to biofilm-associated infections, there are very specific models for infection, such as the endocarditis model with rabbits or the tibia osteomyelitis in rats. But there are some other models which are more transversal. They apply to many different biofilms. And this is one of the models. This is a tissue cage model, which is very important for bone and joint infection. It has given us a lot of information. Very briefly, this is made with guinea pigs or with Worcester rats. What we do is to insert these small foreign bodies under the skin of the animals under aseptic measures. You can see that this is a multi-perforated cylinder that can be that has two lids, and you can see that there's a small hole in the lid, and this allows for inoculation and for sampling percutaneously. And inside the cylinder, we get this small metacrylate foreign bodies that will be the foreign body at the end of the day. So we operate the animals, we wait for some weeks so the animal is healed. We assess the sterility of the foreign body, and then we inoculate a given inoculum of the bacteria. We wait some days. The number of days that we wait for the infection to develop is variable, depending if we want an acute infection, for example, a biofilm of 3 days or a biofilm of 3 weeks. This is important because, as we have said, the older the biofilm, the more difficult it will be to treat. And then we start treatment, for example, for 7 days. And after the end of treatment, we can assess the activity of antimicrobials either by sampling the liquid and then culturing the liquid, or by recovering the metacrylate plates and then sonicating them and recovering biofilm-embed bacteria. So this model has given us a lot of information, as we will see. Of course, after the experimental research, we have the clinical research, we have a lot of observational studies, and we have clinical trials, which is the standard of care for clinical research. Of course, they are more expensive, difficult to perform. They might have ethical issues according to the specific clinical question that we address. And in the case of bone and joint infection and prosthetic joint infections, it is difficult. We need to perform them in referral centers where we can get big samples and so diminish the homogeneity, the heterogeneity of the infection. These are difficult to control variables such as the surgery. This is quite difficult to control in clinical trials, and in bone and joint infections we need to follow up. So let's move on with prosthetic joint. Why are prosthetic joint infections more important than other infections, or why are they becoming so infectious? Well, because they are becoming more and more prevalent. And you can see these two graphs. On the left-hand side, we have the number of devices that have been placed between 1989 and 2007. And of course, there are more and more devices placed in the population because the population is getting older and older, and these devices are, there's more availability of these devices. And even if the likelihood of these devices to become infected has remained the same over time, the truth is that if I get more devices placed, then I will get more devices infected, no? And you can see that the number of infections has raised over time. Of course, the scale in the y-axis of these two graphs is different, but these two graphs are parallel. So the higher the number of processes that I place in my population, the higher the number of processes that will get infected. Just like this. We have some more recent data that you can see here, and you can confirm that the number of infections has raised over time, and the predictions for the next years make prosthetic joint infection one of the most important healthcare problems that we are going to have. So how are, from a clinical point of view, infections? How do they classify? There's a very useful classification that mixes the pathogenesis of the infection with the chronology of the infection according to the moment where the prosthesis was placed. Sorry. And so with this classification in mind, we can talk about early postsurgical infections. And these are infections that are acquired in the operating theater with a small inocula of bacteria, but whose symptoms begin within the first month after the prosthesis placement. And then we have opposing these chronic postsurgical infections, where symptoms would start after 1 month or 3 months after prosthesis placement. We have a very specific type. I won't talk about it. And then we have hematogenous infections, which are sudden infections which are hematogenously acquired because of a bacteremia, and they can happen anytime after the placement of the prosthesis, although it is typical that they happen more than 2 years after the placement of the prosthesis. How do they behave from a clinical point of view, these infections? Well, they are very different one from the other. These two infections, early postsurgical and hematogenous, is what we call acute infections, whereas this would be chronic infections. And they're very different. The early postsurgical infection and hematogenous infections, acute infections, are explosive clinical infections that happen in a few days, a few weeks, with redness, pain, fever, purulent discharge, joint limitation, and so on. And it is quite evident to diagnose them. Whereas chronic infections may be a challenge to diagnose, because many times they just present with pain, and this pain do not start suddenly, but they start very progressively, very slowly over time. And sometimes it's very difficult to differentiate, to distinguish from the pain because of orthopedic reasons, because just the prosthesis is not very well placed or it's a bit loosened. If we are lucky from a diagnostic point of view, the patient might have developed a sinus tract, and this is quite specific from infection. Why is it that some patients develop an acute infection and some others develop a chronic infection? Why is it that? It is because of the etiology. So acute infections are mainly due to virulent bacteria such as Staphylococcus aureus, gram-negative bacilli, or Streptococci, whereas chronic infections are due to not very virulent flora that usually belongs to the flora, to the skin microbiota, such as Staphylococcus epidermidis or capitis or Cutibacterium agnes. And these are bugs that are able to form a very strong biofilm, but they don't have any other virulent traits, so they don't produce a lot of inflammation. So how do we treat prosthetic joint infections? We have already said that foreign body-associated infections develop biofilm, and these are, by definition, difficult to treat infections. So we need to provide patients with a aggressive combined treatment that includes, for sure, surgery. This is the cornerstone of the treatment, and also an optimized antimicrobial regime to reduce the likelihood of relapse. And so let's talk first about surgery. The gold standard is to remove the prosthetic joint, as we have said before, and this is normally due in two surgeries, what is called the two-step exchange procedure. In the first surgery, what surgeons do is to remove the prosthesis and place a cement spacer. The function or the goal of this cement spacer is to maintain the joint space, to avoid the joint collapse. And also we take profit of this because we load this cement with high doses of antibiotics. So we have high concentrations of antibiotics in the joint space. Also, we give the patients systemic antibiotics. And with this procedure, the prosthesis removal and the antibiotics, we hope the surgical site to be sterile enough to receive in a second surgery a new reduction prosthesis. Of course, this is quite demanding. So in some cases, we can do this in just one step exchange surgery. So do everything in one surgery. And in some cases, this is not possible. And for curing the infection, we have to remove the prosthesis, but it is not possible to place another prosthesis. This is what is called a joint arthrodesis. Of course, this is very demanding for the patient. Imagine a patient has to be several weeks with a proper prosthesis. So he's in bed or he's in wheelchair or he can walk, but very slowly. This is quite problematic for the patient. And also this kind of surgeries of prosthesis removal can be quite bleeding. And this may be a problem for elderly patients who have a very well fixed prosthesis. And then it is not enough with just pulling the prosthesis, but they have to do a longitudinal osteotomy, which is quite a bleeding surgery. So it is a problem. There's also the concept of bone stock, meaning that the prosthesis need to anchor itself in the bone. And every time we exchange the prosthesis, then we are consuming bone stock. And this means that the number of prostheses that a limb can have is not infinite. It's like 2 or 3 or 4 exchanges in a lifetime. But this can be quite important for a 50-year-old person who has a prosthesis and has an infection. And then if we remove the prosthesis, then he will have consumed his bone stock for the next 10, 15 years. So this is a concept to bear in mind. And of course, things can go wrong. There are complications, not only the infection, but complications of the surgery. So some patients just end up without prosthesis or end up with amputation. So this is something to bear in mind as a risk. So it's been developed the possibility of treating the infection without removing the prosthesis. This is quite difficult to do because if you remove the prosthesis, you remove the biofilm. This helps a lot the infection to be cured, but it is possible to cure the infection without removing the prosthesis. And this is what is called in the literature DIRE, which is the acronym for debridement, antibiotics, and implant retention. And this consists in a thorough debridement of the joint prosthesis, removal of all the necrotic tissues and the debris, exchange of removable components of the prosthesis, and perform a generous irrigation with saline and antiseptics. And the rationale for doing this is trying to reset the chrono of the biofilm to 0 or the nearest to 0. Remember that the older the biofilm is, the more difficult it will be to treat. So if we clean the biofilm and we just impair the architecture of the biofilm, bacteria will have to restart in a way. And so this biofilm, we believe that is more susceptible to antibiotics. Of course, not all patients are candidates for a DIRE management. These are the Zimmerli criteria. And what these criteria do is to help us to select the best candidate for DIRE. What patients may benefit from DIRE? Those with an acute infection mainly, because the biofilm is still young enough to be treated. These are patients with early post-surgical infection or acute hematogenous infections, and also patients that have a short duration of symptoms. So the biofilm is not mature again. Of course, the prosthesis needs to be well covered by the surrounding soft tissues, and the prosthesis needs to be well fixed. If the prosthesis is loosened, there's no point in keeping it. Ideally, we need to know the microbiology before. This is not always the case, but we need to know that the microorganisms are susceptible to antibiotics with good antibiofilm profile. So at the end of the day, when I have a case of prosthetic infection, I have 3 options. One is eradicative attempt, a curative attempt with prosthesis removal, which is the rule. In some cases, I can perform a DIRE, which is a eradicative attempt with implant retention. And in some cases that the prosthesis is performing well, but I have no warranties of curing the infection. If I remove the prosthesis, I can try to not to heal the infection, but to maintain the prosthesis with a suppressive antimicrobial treatment. But I have to select very, very well the patient here. Of course, this decision is not easy. We have to bear in mind patient's preference and expectations, patient baseline conditions, the results of salvage therapy in case of the primary therapy fails, the availability of biofilm, active antibiotics, and so on. This is difficult to do, and so we take this decision on a multidisciplinary basis with the orthopedic surgeon, infectologist, microbiologist, and also the patient. What about the antibiotics that I can give the patient? Of course, the antibiotic should have these properties that I show up here, should have good diffusion both in bone tissue and in the biofilm, should have good activity against biofilm and also against intracellular bacteria, because as we have seen, this makes part of the problem, and they should have a good safety profile that allow long-term administration. So in the following slides, and I will end up with this, I will discuss the main options according to the etiology of the infection. Staphylococcus aureus is the most frequent microorganism causing Clostridium infection. And in this case, we have rifampin as the treatment of choice. Rifampin has been developed in a very beautiful bench-to-bed strategy by the Swiss School of Infection, of Bone and Joint Infection, and specifically by Bernard Stimmerli, who directed this research. And in the Guinea pig model, they proved that rifampin was the most active antibiotic against biofilm-embedded staphylococci. Of course, as you know, as it happens with other infections, for example, tuberculosis, we cannot give rifampin alone because it develops resistance very easily. So we have to give rifampin in a combination with a second drug, and fluoroquinolones are probably the best companion to rifampin. This same group, Zimmerli, developed, which is the most important randomized clinical trial to date in bone and joint infection, in Clostridium infection, where they compared the outcome of patients with Clostridium infection treated with ciprofloxacin versus ciprofloxacin plus rifampin. And you can see the dramatic difference between the rifampin group, where no patient failed, as compared with the ciprofloxacin alone, where patients failed. In fact, they had to stop this trial early. The thing is that even if the number of patients recruited was low, they could prove their point, and further observational studies with a high number of patients, look, 98 patients with Clostridium infection, or this study that was performed in Spain with more than 300 patients with Clostridium infection managed with implant retention. In this case, rifampin-based combinations showed to be protective for failure. So rifampin is well sustained. Other gram-positive cocci, such as Streptococci, we don't have that much evidence. In a very large study that we performed in the European group of implant-associated infection, we could compare different regimes, including beta-lactams plus rifampin, which was the most successful regime, but it was not different from other regimes with rifampin or just beta-lactams. What we learned from this study is that if you have a Clostridium infection caused by an Streptococci, then you should use either beta-lactams or rifampin, and ideally both of them. What about other gram-positives that are common suspects in prosthetic joint? We have Cutibacterium agnes. In the Guinea pig model, we received this information showing that rifampin-based combinations were beneficial for foreign body infection caused by Cutibacterium agnes, but this couldn't be confirmed on clinical grounds. This is the largest study made with patients with Clostridium infection caused by Cutibacterium agnes, and you see that patients treated with rifampin seem to perform better than patients treated without rifampin, but this was not significant from a statistical point of view. So we are not certain of the benefits of rifampin for Cutibacterium agnes. What about gram-negative bacilli? We know, again, thanks to the Guinea pig model, that ciprofloxacin performs very well against foreign body infection. You can see a 99.9% of killing in this model of infection, as compared, for example, with cotrimoxazole, that wasn't able to heal any of the animals. On clinical grounds, the differences are dramatic. When we can use ciprofloxacin, the odds of curing the infection are quite high as compared with other treatments. See, this is the largest series ever published of Clostridium infection caused by gram-negative bacilli treated with implant retention, and you can see that patients treated with ciprofloxacin were cured 79%, whereas those with other treatments 41%. And this applied also to specific bugs such as Pseudomonas aeruginosa or ESBL producing Enterobacteriaceae. What happens when we don't have ciprofloxacin? Well, in this case, combinations of colistin and fosfomycin seems to be promising. This is again the Guinea pig model, and you can see that monotherapies weren't able to cure any one of the animals, but combinations of colistin plus gentamicin, tigecycline, fosfomycin were able to cure a significantly higher proportion of animals. In this regard, we believe that colistin, and we have Jaime here, who is the world expert of colistin. We believe that colistin has a specific role in the biofilm. Colistin is able to kill bacteria in the deeper layers of the biofilm where there's almost no oxygen and nutrients. And this is quite different from other families of antibiotics. So colistin could have a complementary target that would allow for a subpopulation synergy with another antibiotic. This is an example of colistin plus tropomycin. You can see that when we use colistin or topramycin in these live and die and death photographs, we have a killing of part of the population, but when we use both antibiotics together, we have a universal killing of the population. In this regard, I myself, in the laboratory of Jaime, could test some Pseudomonas aeruginosa, which were multi-drug resistant, were carbapenem resistant and colistin susceptible. We tried them with the CDC biofilm reactor that, as I was mentioning, is an in vitro dynamic system that allows to perform long experiments with PK/PD data, and we could prove some synergy and additive effect of doripenem and colistin, even if doripenem was resistant. In fact, we have just conducted, and we're about to publish, this study, which was performed in several hospitals in Spain. This is a prospective, non-comparative study assessing the efficacy of colistin plus perlactams for bone and joint infections caused by fluoroquinolone-resistant microorganisms. We could recruit 45 patients. These are elderly patients with comorbidities, as you can see here, and we treated them with colistin plus perlactams for 4 weeks, and then perlactams for 2 more weeks. These were patients that have different kinds of bone and joint infections, osteomyelitis, orthopedic-related infections, and prosthetic joint infections. Overall, 3 every 4 patients had an orthopedic material, and half of them were treated with implant retention, so maximal difficulty. You can see that most of the infections were caused by E. coli and Pseudomonas aeruginosa, and overall, more than half of them were multi-drug resistant or extremely drug resistant. Well, the rate of cure rate was 87%, and this is with a small follow-up. We have to extend the follow-up still, but these are promising results for the combination of colistin with another antibiotics. Fosfomycin is the only, to my knowledge, the only antibiotic with a Spanish patent. So we are very proud of this antibiotic. This is a very small molecule that has a unique action against bacteria, inhibiting the conversion of the activity of the phosphoenol pyruvate transferase, and thus impairing the formation of the peptidoglycan in the cell wall. As it is the case of colistin, fosfomycin is able to act in the deeper layers of the biofilm, and this is quite unique, as I was saying, and this is because fosfomycin uses these 2 proteins in the bacterial wall to get inside the cell, and these 2 proteins are enhanced in the situation of anaerobiosis, so at low concentration of oxygen, as it happens in the deeper layers of the biofilm. There are some in vitro systems. This is another reactor biofilm that proves that the combination of quinolones plus fosfomycin is beneficial as compared with either monotherapy. So in summary, I think we can say that biofilm is the most common state of bacteria in nature, and it is a protective tool for bacteria to survive in hostile environments. Biofilms are very difficult to treat. Among other reasons, biofilm-embedded bacteria become tolerant to antimicrobials, although not in the same measure for all antibiotics. Treatment of biofilms needs a combined aggressive treatment, both surgical and antibiotic, but with an optimized regime of antimicrobials. And in the particular setting of prosthetic joints, acute infections may be treated successfully in spite of retaining the prosthesis. Rifampin combinations are the treatment of choice for staphylococcal infections. Fluoroquinolones are the treatment of choice for gram-negative bacilli, and more research, both in the bench and at the bedside, is still needed. So thank you very much for your attention, and I'm happy to answer any questions you might have.
Great talk, Jaime. Thank you very much. I think clearly this is a very important topic. Now this presentation open to questions. Any question from audience? So Jaime, while we are waiting, I have a few questions. Maybe let me ask your first question. for the different joint infections, from the PK/PD point of view, all the different joints do they have similar sort of drug exposure for a certain antibiotic, or they could be very different?
That's an excellent question, Jan. Thank you. That's an important issue because when we have a prosthetic joint, the way of antimicrobials to reach the joint space is by different tissues. So we have to think on the synovial tissue, and the synovial tissue is a good tissue. Antibiotics diffuse very well in the synovial tissue, but then we have some interface of the prosthesis with the bone, and in the bone, the diffusion of antimicrobials is different, and it depends on the whether it is cortical bone or a medullary bone. So of course, PK/PD is quite different regarding prosthetic joints. I think that for us, at least for us clinicians, it's the same a hip joint, as a knee joint, as a shoulder joint, but there are many different tissues involved, and so the PK/PD is quite tricky. And in fact, there's some evidence suggesting that, for example, in the case of beta-lactams, it is not the same treating patients with continuous infusion that optimize the PK/PD properties of beta-lactams as giving boluses. No, so prosthetic joints are difficult to treat infections such as neutropenia and other infections. So giving beta-lactams in an optimized way enhances the PK/PD properties of beta-lactams.
Great, thanks. I think there's another question from the audience. I think let me try. So Sue, could you please help unmute?
Right, I think that's great.
Great.
Hi, may I go ahead, please?
Absolutely, please go ahead. Yes.
Hi, this is Ashwini Chauhan from India, northeast part of India. So a very interesting talk on prosthetic joint infections. I'm a basic scientist working on biofilms. So my question is, since prosthetic joint does not need, it does definitely need a systemic therapy, is it possible to locally administer other compounds in combination with antibiotics? For example, EDTA, which can dissolve the biofilm matrix, or N-acetylcysteine, which is lower in pH but is able to act on the EPS. Is it possible to give those kind of combinations to make the the clinical outcome effective? Or L-arginine, which is higher pH, but all these are FDA approved molecules and can be given for treatment.
I think this is a very, very interesting question too. Thank you very much. Of course, I have just talked about antimicrobials in my talk because I had no time. There are other strategies for treating prosthetic joints which regard specific ways of administering substances, such as the one you are mentioning. Also, alternative to antimicrobials, such as the use of bacteriophages or mechanical, electrical, physical properties, and so on. In the particular case that you are mentioning, which is administering some other antimicrobials locally, there's some research. In my opinion, we have two problems there that we have to deal with them, but I think we have to address this research. One is the toxicity. These compounds need not to be toxic. And the other is the way to administer. And this links to the question of Professor Lee, because it is possible to provide local antibiotics or local substances in a joint. You can just puncture it and just provide antibiotics. But the diffusion of this antimicrobial or these substances is very heterogeneous. And I wonder, it is very difficult to be certain on how much amount of antibiotics gets to the interface bone prosthesis. If you have removed the prosthesis and you have only just a joint space, okay, that's a way of doing. And in fact, in this sense, there are some groups that have tried just local antibiotics in the joint space once they have removed the prosthesis with a high rate of success. So I think that's not the problem. The problem is when we keep the prosthesis in place. And in this case, I wonder in what way we can administer antibiotics, being sure of the diffusion of the antibiotic in the interface bone prosthesis. I don't know if I made myself clear with this.
All right. I see there's another question from the audience. Sue, could you please help?
Yes, I have unmuted. So if you
Thank
could
you.
just unmute yourself, Sally, that would be great. Thank you.
Thanks, Sue.
Okay, hello everyone. Hello.
Hi, we
Hi,
can
we
hear you.
hear you.
Thank you. I would like to thank for this valuable information, and I want to state my question. My question is the rate of the acute kidney injury with the use of the colistin while treating this biofilm. Is there any research done to find the mortality rate? Because most of the ICU patients are from the AKI population. So I want to ask if there is any guidelines while using colistin and treating them.
Thank you for the question. Of course, the rate of colistin related nephrotoxicity was high in this cohort of patients. It was around 40%, which is a lot. There were no deaths, and all patients recovered their renal function when colistin was removed. So I think that when we use colistin, we are not certain if we have to use colistin for this scenario. We need to see a randomized clinical trial. This was a non-comparative study, the one that I was showing. But if we finally, I myself do it with some patients that I really need to heal their infection with the prosthesis, and I don't have fluoroquinolones. So I use colistin plus another antibiotic. And then I think that what we need to do is to monitor very closely the toxicity of the patient, no? And whenever we have a rise in the creatinine, we just remove the antibiotic and so on. There are no guidelines, specific guidelines for the use of colistin in bone and joint infection. We have the guidelines published by other groups, and so the recommendations is to use 9 millions as a loading dose, and then 4.5 millions every 12 hours, assuming that the renal function is okay. I am not certain myself that we need these high concentrations or these high doses in the particular setting of bone and joint infection if we're using it with another antibiotic. But again, this hasn't been addressed yet, so the recommendation is the same as other infections.
Okay, thank you very much.
Thank you for the question. Any other questions? I got another one, Jaime. I mean, I think in general, biofilm animal models are quite difficult to set up, and also there's not strong evidence to show the translation from animal biofilm model to clinical settings. Even in the clinical settings, I think there's still lots of unknown questions. So what's your opinion about this, this kind of, which kind of animal biofilm model shall we use to do the clinical research for the clinical translation?
Thank you, Jan. I agree with you. Animal models are very, very demanding. They consume a lot of time, resources, people, money. So, and there are ethical issues, of course, in there, no? So you have to choose the ballot. If you are, you have to think on the specific biofilm that you are treating. It is not the same an intravascular biofilm, such as the one in endocarditis, as an extravascular biofilm, such as the one in prosthetic joints or other infections. So this is important because results can be different. In the particular case of prosthetic joint infection, we have all the experience published by the School of Bone and Joint Infection in Switzerland, and they use the tissue cage model. The tissue cage is quite unspecific because you are treating a very unspecific biofilm. But the truth is that the results that they got with this model were quite extrapolable to the clinics, at least with the staphylococcal infection. In this case, this is a very beautiful example of from bench to bed extrapolation of knowledge, because they found that rifampin was quite active, and then tried in the Kenia-PIC model, and they had very good results, and then just tried it in a clinical setting, and they could prove their point. So I think the tissue cage model is a good model for foreign body extracellular extravascular infections. And it is cheaper than other models, such as the osteomyelitis model or the rabbit model.
Great, thank you. I think we can have the last question. I think there's another question from the audience. So Sue, could you please help?
Yes, if you could please unmute yourself.
Hello, am I audible?
Yes, you are.
Yeah, we can hear you now. Yes, please.
Okay. It is not specific to prosthetic, but in general about the biofilms, particularly about the penetration of biofilms, antimicrobials through the biofilms. Is there any animal model will you suggest for studying about the penetration of antimicrobials through biofilms?
I'm sorry, I didn't quite understand the question. Can you repeat it again?
No, I'm talking about like animal model, it is okay to study in vitro, or should I proceed to animal model as well after in vitro results regarding the penetration of antimicrobials in through biofilms? Can you?
So Jaime, he's asking, is there any animal models which can be used to investigate the penetration of antimicrobials for the biofilm infection?
Oh, all right, absolutely. Thank you. That's a very nice question. There are some in vitro models that address these specific questions. They are in vitro models mainly, more than animal models. Still, in animals, you can well, in fact, you must do PK/PD studies. So you have to know what is the exposure of your animal to the antibiotics. But in the specific biofilm tissue, there are some animal, some in vitro models that allow you to address the specific quantity of antibiotic that you may have. Absolutely, yep.
All
Thank
right.
you.
Thank you. So considering time, we're already 4 minutes past 1 hour. So we held closed session, but before I close the session, please join me to thank Jaime for the very informative and very nice presentation. And also, I would like to thank the great help from Sue and Clay, who both help and did lots of hard work behind the scene. Also, Professor Zhihui Hou and Pingping Wang from China Agriculture University, who provide lots of support to this webinar as well. And finally, thank you for your attending this webinar. And I know, particularly for Jaime, right? He's on leave, and I'm really grateful for him to invest time and put lots of effort into this this webinar. And if you celebrate Christmas, and I wish you and your family a very Merry Christmas and Happy New Year. Thank you all. So now this webinar
Thank you very much.
Thank you, Jaime.
Thank you very much.
Everyone. Bye-bye.